Good morning. I'm Sherry Williams. I'm the Chief of Operations with the Global Partnership for Telehealth, and I'm honored to serve as the moderator for this panel as we discuss virtual health. The panelists we have joining us this morning is Ann Mon Johnson, the CEO of the American Telemedicine Association, Leah Sims, Marketing Strategy Lead with Verizon Healthcare, and Nate Lackman, Partner and Chair of the National Telemedicine and Digital Health with Foley and Lardner LLP. Good morning and welcome, panelists.
Good morning.
As we all know, around April of 2020, healthcare systems and providers were forced to make major shifts in the way they were delivering healthcare. Overnight, telehealth became a household term, and as the days have moved forward, virtual health has become a common expectation of most patients. Today, this panel is going to take a deeper dive and begin to pull back the covers on the impact COVID has had on digital healthcare and the direction that the industry is heading. Our first topic is going to be more of a level set, just so that we are all speaking in commonalities when we're talking about digital and virtual healthcare. And I'm going to turn it over to Ann. Ann, can you explain to us how we're going to be talking about virtual healthcare today, and what does it mean for health systems and providers and patients?
So I think that's a great way to open this because there are a lot of definitions out there: telehealth, telemedicine, virtual health, digital medicine. And what we've done as an association, and the way we've been able to attract such a broad membership and a diverse membership, is have come up with the definition that telehealth effectively connects individuals and their healthcare providers when in-person care is not necessary or not possible. And using telehealth services, patients can receive care, consult with a provider, get information about a condition or treatment, arrange for prescriptions, and receive a diagnosis. And this has been a modality of care that's been in use for over 25 years. And so when we talk about telehealth, we're talking about what we're doing right now, which is video, but it also includes audio only. It includes asynchronous chat, text, store and forward photos. So it's just a very broad definition. And I think that's really important. What's happened then is, while telehealth has been around for a long time, clearly before the pandemic, the uptake and the engagement was pretty light by both consumers and physicians. And so today, what telehealth is universally, in my estimation, our estimation at the ATA, is becoming the way to reach people where they are. So if you believe that our vision is to ensure that people get care where and when they need it, and that when they do, they know it's safe, effective, and appropriate, while enabling clinicians to do more good for more people, then really telehealth is part of that equation. And I know we'll get into it later, but there have been so many stories and incidences of how telehealth has really proved its mettle during the last 20 months, right? With, texting and with remote patient monitoring, keeping people safe at home, enabling clinicians to still provide care to their patients. So it's a great time for the industry and lots of change. And I think that from our vantage point, what we want to ensure is that telehealth is not a pandemic only tool, and that we also make sure that we drive the conversation on what virtual hybrid care looks like, because telehealth is not for everyone, for everything. And then finally, one more thing that I'd say we're focused on that has really come to the surface is the issue we have as a nation, as a society, in not getting care to everyone equally. And so we have an opportunity, and I always say we have an obligation to fix that and to make sure telehealth is used accordingly. So.
Thank you. Nate and Leah, I'll pose this question to you guys. As we've seen telehealth being used more and more throughout the past 20 months than we've ever seen it previously, what applications are we seeing telehealth being used in? Are we seeing it more in the direct-to-consumer model? Are we seeing it more in clinic-to-clinic? What are some innovations that you guys have been able to look at over the past couple of years that are of note?
Nate, you want to take that? I can follow.
Sure. It's funny, the other day I was talking with a founder who referred to old school telemedicine, which is almost refreshing and really reflective of the rate of change and proliferation that primarily like tech funded entrepreneurs have applied, demonstrating to the incumbents and hospital systems and established more traditional players how you can use these tools and new technologies in creative and effective ways that both derive patient satisfaction as well as provider satisfaction, reduce burnout, and ultimately are medically appropriate in accordance with the standard of care. Some examples of more niche practice areas or specialties that we've seen emerge in the last few years in particular are opioid, OUD, and SUD treatment operators. And some of their early clinical studies, they're still in development, but I've seen some like drafts are showing much higher adherence rates, namely like the relapse likelihood is significantly lower when an individual is on a virtual care OUD or SUD treatment program because they have that continued continuity of touch points, right? They don't feel as lost, and it's not just occasional, hey, go to your in-person clinic for your Suboxone and buprenorphine refills and whatnot. So I really like to see these kind of applications. Similarly, for trans patients, there's a HRT and other hormone replacement therapy programs coupled with patient-specific needs for medical and mental health services. Areas that wouldn't otherwise be available if you're just like walking down Main Street of your local town saying, oh, who do I go to if I'm trans and I need medical services? I really like those type of use cases that have emerged in the last couple of years, the next level non-traditional style telemedicine.
We've seen the same thing during COVID. I think, you know, the numbers sure reflect that behavioral health has been forever transformed by telehealth. And we're seeing some interesting use case deployments on our side as well. We're working on our public sector side with deploying our telehealth capabilities with law enforcement, because they're looking at positioning in-field, on-scene behavioral health support in law enforcement, which is greatly needed. We're also seeing a lot of requests for it by the public school system, positioning telehealth and ready access to behavioral health support in nursing clinics in schools to support the behavioral health of our kids, especially right now. So those were some interesting use cases I don't think we expected going in, and we're seeing a lot of interesting conversation there. But I also think that COVID changed the conversation around what telehealth is from a care anywhere perspective, because we supported a lot of deployments during COVID right there in the hospital, deploying telehealth capabilities that enabled nursing teams to communicate with COVID patients in isolation to reduce the number of times they were going in and out of a patient's room and consuming PPE. This was, you know, really critical during COVID. So I think, and our traditional definition years past of looking at telehealth as and it still is critical, obviously, to reach rural communities and those who don't have access issues, but it doesn't mean anywhere has to be across the county. It could just be on the other side of that glass window to support the way care teams are communicating. So we're seeing a much broader definition of telehealth than we would have expected prior to COVID, which is exciting and is transforming, you know, the way we think about virtual care. Anyway.
Sherry, if I could just add, I think what Nate and Leah are pointing to is something that, if you think about it from a delivery system perspective or a provider's perspective, people's experiences have changed dramatically in the last 20 months. Lots of people have tried telehealth, both patients and providers, and consequently, their expectations have changed. So I think the message for the delivery system is you'll have to accommodate them as well. And you can't leave it to others. You have an opportunity as well to step up and engage with consumers in a virtual fashion.
Yeah, and there's even ways that people are using telehealth technology that you might not think is a traditional doctor-patient clinical experience, right? There are companies that are essentially infrastructure plays serving other virtual care providers, whether it's on-demand clinician staffing or whether it's ways of using distributed models of having clinicians located all over the country to manage the ebbs and flows of consumer patient demand in new and better ways. I really like that because these are primarily tech-forward solutions that are only possible through the use of these high-speed bandwidth kind of communication technologies would not even have been conceivable 2 decades ago. And so I like that because it's a way to show how inequitable the access has been prior to the proliferation of this technology. Because there's been some criticism for behavioral health apps and the startups. Oh, they're oversold, right? There's not enough access to the members who want that kind of care. Well, that just shows you what it was like for people before these type of tech forward companies even existed. It was almost inconceivable that I could get care, right? Particularly if you're struggling with mental or behavioral health issues, you're not really in the best place to logically and rationally find the practitioners that you need.
Thank you very much for the description of what we're seeing with telehealth and digital healthcare at this point in our lives. So as you've all mentioned, COVID has really put an underscore under virtual care and digital healthcare. It's a very common term, whereas before, I don't think the general masses were had a really good understanding of the breadth and the depth of this type of healthcare modality. It appears that consumerism of healthcare has hit warp speed. I think consumers are driving the market right now, and may or may not continue to do so in the future. We've also been blitzed with waiver after waiver during the public health emergency. And I think it's a little overwhelming at times. We can look at the data and we can easily see that telehealth utilization during the heydays of early COVID life was really high. I think we've seen an ebb and a flow of that depending on where we are in the virus cycle. My question now turns to what's going to happen moving forward. I mean, I think we can look at this in terms of, who knows what, days, weeks, months, years. What's going to stay permanent, and how do health systems navigate this new world that we find ourselves in? And then, on top of that, how will health systems answer the demand and the desire from patients to have more virtual care options? Nate, back in February, your firm conducted a study that looked at telehealth commercial payers. And at that point in time, it seemed, everyone was following CMS's lead on that. But now, as we're 20 months into this, there's data coming to the surface. And I think our payers are beginning to look at that data and are beginning to shift and kind of follow their own direction somewhat. Can you lead us through where we've been, where we're going, what you see in terms of permanency with our waivers, rules, and payment parity?
Sure, that's a large subject. I think that when you take the COVID-related way, and to be clear, I've said this before, COVID did not create the telehealth industry. It merely accelerated what was, I believe, to be an inevitable adoption, right? Concrete example, my father's 83. In the last 18 months, he's had online virtual second opinion from an academic medical center 5 states away. He's engaged in remote patient monitoring for his heart needs and used telehealth consults. And he's like, Nate, this is great. I was like, Dad, what do you think I've been doing with my career for the last decade? So it really, to the inside folks on this call who live and breathe it for so long, it was almost like, yeah, this is manifest, but the public at large, it took something to really move that needle faster. I think in the waivers, there's 5 categories that we can talk about primarily, and it's licensure, it's practice in medicine, it's prescribing medications, it's privacy security, and it's payment. So a lot of P's in there. I couldn't come up with another P in lieu of licensure, but in any event, 4 P's in and out. And licensure, a lot of states eliminated their licensure requirements. Those are already closing up because many of the state emergency timeframes do not match the federal PHE. So again, that's paperwork. There are some solutions in play talking about trying to have on a federal national basis. We'll see what happens with that. The second is practice. So whether it's in-person exam requirements or technical practice standards for things you need to do to create a valid doctor-patient relationship, a lot of those have been waived to make it easier to onboard. Examples of that is audio only for brand new patients. Prior to the waivers, most states prohibited that, right? Executive orders waived it. And in fact, some legislatures have made that permanent on a go-forward basis post-COVID. The third is prescribing, and whether it's non-controlled or primarily controlled, the DEA, one of the exceptions to its federal law is if there's a public health emergency, we have that right now. And so you can prescribe controlled substances without an in-person exam. Many states have also followed suit, really even permanently. There's only about 14 states that actually mandate some sort of in-person exam or other esoteric restriction on prescribing controlled substances. So in some ways, the states are further ahead of the federal rules on that. The fourth, privacy, HHS OCR said we basically have waivers on enforcement discretion of privacy breaches for HIPAA. That will eventually sunset when the PHE ends. I would note, though, a lot of these direct-to-consumer or cash-only companies are not even subject to HIPAA because they don't submit claims electronically to third parties. And just yesterday, the FTC put out a new policy statement saying, I don't care if you're not subject to HIPAA, you still have obligations to your users to keep their private health information private. And they've stepped up significantly this year during COVID, their enforcement actions against digital health apps, telemedicine companies that are improperly sharing user data. And then the fifth is payment. That's a big one. There's payment parity, there's coverage. About 42 states do require some sort of coverage telehealth services for health plans. And a number of states put waivers requiring that even further. Some of them have been rolled back. Massachusetts one, for example, that expired this previous Monday. And a number of smaller providers in particular are concerned that they're not going to be able to continue to serve their patient populations via telehealth, particularly if it continues to be a covered service, but reimbursed at a mere fraction of what the provider would get paid in person. So those are some of the moving parts. I don't want to just talk too long. Let's kick it over to maybe some of the other panelists who can share their thoughts on these waivers.
And one of the things I would like the panelists to address is the consumerism of telehealth. I think, Nate did a great job of talking about parity and where we're moving. But where's the patient tolerance? If insurance companies decide for whatever reason not to pay at a fair rate, and the physicians decide they don't want to do telehealth with their patients, where's the patient's tolerance with paying out of pocket? Can you mention that in terms of what you're seeing, where you think we're going to go, and maybe tie that back into the waivers that we're seeing?
Yeah, you want to take it?
Well, I can share that this time last year, Verizon Media Group, which we've recently divested of, but we leveraged our Yahoo and AOL properties to do some extensive surveying of consumers about patients about their experience with telehealth through COVID. And actually, we did 3 consecutive surveys over the course of about 6 months to see where their thinking and affinity and comfort level with telehealth was migrating. And the results were encouraging and somewhat surprising in some cases. There was a much stronger affinity for it, which grew over time as patients got more comfortable. We didn't see a huge split in demographic where we might have expected to see, millennials or younger more comfortable with it, and those aging in place populations less comfortable. And we had a good mix of folks who responded to the survey. If there was an ease of getting into the visit and there weren't technical issues, they responded very favorably, found it to be very convenient. We didn't address the issue of out-of-pocket pay. Of course, that wasn't an issue at the time. I do think that will be one that will emerge depending on what the threshold of that cost is. If it's a $10 quick telehealth visit, I think most people would be willing to absorb that, but it really depends on what their coverage is and where that threshold will be. But we found that the patients that we surveyed, the consumers we surveyed, were very favorable to their telehealth visits, much more so than they expected to be, and felt they got the same quality of care, if not better, through their telehealth appointments than they did in person. And when we gave them an opportunity to expound on that, many of them said, I felt like my clinician looked me in the eye and had more face-to-face contact than I normally get even in his or her office, because the format of being virtual really forced that face-to-face connection and required that, and they felt like they got more attentive care in some cases than they had before. So I think they're favorable to it. The payment and reimbursement issues, I think, still need to be solved for, and whether or not the patient will assume all of that cost out of pocket versus hopping in the car and going down to the doctor's office, I think remains to be seen. But I think the cat is out of the bag, so to speak, in terms of the convenience of it and how much patient populations like it and want to use it more.
And I would just add that not only is the cat out of the bag or the toothpaste out of the tube, whatever expression we want to use, I think that in terms of whether or not consumers will absorb the costs, more important is their response and how it's going to have them push their employers on the benefit side. So large self-insured employers have really been leading the charge in a lot of ways as it relates to virtual services, because they want to support their employees. We have a tight labor market, notwithstanding data that we might see to the contrary, but in point of fact, it's been tough for employers. And so they want to make sure that they invest in their resilience, they invest in their workers' well-being. So I think the employers are important, and consequently, the payers are getting that message also. So I think that you'll see a lot of, there are some pretty innovative payers out there in terms of what they're doing to use telehealth to close gaps of care. They're worried less, I think, about utilization because they know people have to access services both virtually and in person. But I think what this points out to is really the heading of our topic, which is how do we roll this out and how do we sustain this going forward, which is the whole operationalizing of virtual care. How do we equip physicians, equip patients to navigate and get themselves to the right place at the right time? So they want to do it. And I think that what we'll see increasingly is consumer expectations will go in that direction.
I think the
point
provider,
about,
go ahead, Nate. No problem. I didn't mean to jump in.
let's say Ann's point about payment is particularly salient. Even in some states that did not mandate commercial insurance companies to coverage telehealth services during COVID, I can't think of a single one that didn't, right? So sometimes I understand when you're holding the bag for money as the health plan, they don't want to be saddled with a bunch of mandates, particularly if they don't feel that they're appropriate for moving their members' care needs. But I think a lot of plans have realized this is actually not a budget buster whatsoever. This has been able to increase our member satisfaction, manage our medical spend, and ensure that we're actually providing the access. That's primarily what health plans have to do, access quality care. So I think that a lot of these changes will continue on voluntarily. And then to Ann's point, it will absolutely be a competitive differentiator when open enrollment comes around. For MA plans, Medicaid MCOs, a lot of them are just providing free technology, hardware, software to prospective members in order to get them onto RPM programs, telehealth, and then these virtual first health plans and virtual first primary care plans. They will absolutely, they basically took some of the lessons learned in the retail only cash pay DTC models and just applying them and using their larger infrastructure. We have a tweet chat every other Wednesday night at 8 p.m. Eastern called #TeleMedNow. And the one yesterday was exclusively about payers and virtual care. And half of the time it was all, okay, what are these virtual first companies, models doing and how are they using it as a differentiator in open enrollment?
Mm-hmm.
And Leah, you had follow up to that?
I was really going to touch on what Ann said about, some of the greater challenges I think still lie on the provider side, the interoperability issues, making sure that we're creating virtual care models that map very intuitively to their workflows. They're now really looking, unless they're a virtual first practice, and a virtual only practice, they're really looking at a hybrid care model, and something different than we've ever seen on the provider side, where they're looking at, how do they prioritize their on-site care? How do they, care for their virtual patients in the mix of that throughout their day? How do they now manage scheduled and ad hoc synchronous and asynchronous telehealth as part of their workflow? This is a complexity that I know everyone's solving for, but it's really critical, I think, to provider not only affinity for telehealth, but really engagement with it and advancing it across the care models for their practice. I think private practice is changing, and it's not going to look like it did 5-10 years ago. It's not going to look like it did 2 years ago prior to COVID. But the good news, I think, if we can solve for some of these complexities for providers, what we're going to enable is more close, consistent connection to their patients that previous models have not been able to solve for, especially when it comes to managing chronic disease. virtual care and telehealth is going to enable them to stay much more consistently connected with that patient. And when you look at the integration of RPM data and wearables data and the intersection between a virtual visit and their remote patient monitoring trials and programs, what you're then doing is surfacing through a single pane of glass this 360-degree view of their patient's health and wellness and activities in a way that we've been all talking about for years would be ideal. But now we're really seeing it unfold. What that's going to mean for the provider is, a better understanding of not only their patients' compliance and adherence, which is critical to, the chronic disease management and, readmissions and all of those things that they're tracking, but really having a better relational connection to their patient on a more consistent basis. This is transformative for clinical practice. And I think if we can help get over the hump of interoperability and figuring out how all these things stitch together, this is the future of healthcare, and it's exciting. But I think the challenges are much more on the provider side than the affinity of patients for telehealth and their willingness to pay for it, or who's going to pay for it. I think those things will get solved. The other issues on the provider side, I think, take us all to roll up our sleeves and work to make that happen.
So I would add a couple of stories to this. One is my sister-in-law has a cardiac condition, and she was out doing housekeeping chores for her other sister who was moving out of her home. And she got a call from her physician's office saying, "What are you doing?" Because she was wearing a monitor, and they were able to flag her. The office was able to flag her. And not only did she feel comfortable that he had known, or she had known what was going on, but she also felt this closer relationship, as Leah talked about. So I think that it speaks to what Drew Schiller at Validic talks about, which is remote monitoring and enabling clinicians to monitor patients and surface what's not going well easily, allows them to practice at the top of their license. So instead of feeling threatened by the technology, what ends up happening is if they deploy it and understand how it can be used to their advantage and to their patient's advantage, it actually provides a better experience for everyone all around and closes those gaps of care.
To Leah's point, she said this is the future. I mean, it is. It's not going away. It's not going anywhere. The only thing that I could think of that may significantly reduce telehealth is proliferation of pure AI as like software as a medical device. And so people may 20 years from now look back at all these DTC async and it's just as an interim step, right, towards it. But make no mistake, there are entire generations of people who grew up living and breathing e-commerce. That's how they communicate. That's how they purchase, sell goods and services. That's the way they want to interact, not just with each other on a social media basis, but with their professionals. We've seen it in banking. We've seen it in finance. It's happening now in healthcare. So even if you as an individual clinician may not buy into the tech, or you're like, oh, I'm too old school for tech. Unless you plan on retiring in 5 years, if you want to have a future thriving practice in US society medicine, you have to understand how this medical telehealth technology is to be used. Otherwise, you are making yourself obsolete. It's not necessary. That's the truth.
Mm-hmm. Great.
Nate, that plays right into the next topic I want to bring up, and is that of business models and investor dollars. Whether we wanted to or not, when the COVID pandemic hit in 2020, we were all faced to look at how we were currently doing business in the healthcare industry, as a health system, as IT providers, telehealth providers, whatever it may be. So we had to really take a really fast look at how we were doing things so that we could all remain viable. I can't help but to think about how investor dollars are changing a little bit, and how companies are really rethinking going forward how they're going to do business. There's also been a gigantic insertion of startups into the market, which has saturated the market quite a bit. what's this going to look like for us in the future? Where are, where is our dollars going? Leah, I'm going to ask you this question, and then maybe Nate can follow up with a response to it. But you are in the space of marketing with Verizon, and I know that you're thinking about this. I know this is something you look at every day. How do companies keep up with what's happening? Where do you see the winners in this space being? And then Nate, if you can follow up talking a little bit about raising funds, where are you seeing that happen? So Leah, I'll turn it over to you.
Yeah, I would say in general, as a company, we consider this space, as well as many others, very partner dependent. We look to our ecosystem of partners, and we're watching that there's a whole lot of M&A going on in healthcare. We watch it every year. As you said, a lot of startups. To Nate's point, 2/3 of the startups in healthcare for the last couple of years are leveraging AI in some meaningful way. And so that certainly, is something for us to watch. I think those who are going to be successful are those that realize they can't solve for all of these issues alone. We know what our core competencies and strengths are as a business. We're very focused on the secure connectivity and collaboration capabilities that underpin telehealth and virtual care, which are very critical. And obviously, as a telecom, we get a lot of questions about how we're addressing digital divide and broadband and making sure people can have connectivity. So that's a big focus for us as well. But we rely very heavily on our partners. We just announced an integration with our telehealth platform with Apple Health. We recognize that we have a shared interest of positioning, the right data in the right moment of clinical conversation. But we're not the clinical data company that can do that. We're the connectivity and collaboration partner that can do that. And the most successful ventures are those where you're pulling the right strengths and competencies to the table, and you're building a new model together and advancing that. That's not to say that there aren't some great solutions that single companies are pushing out to market, but I think if you look behind any of those, you're still probably going to find an ecosystem of partners that have had to come to the table to help build that thing and bring it to the market. And so, the other thing I would say that we're seeing is a blurring of lines between industries. There's a lot of overlap between retail and health right now, not only because that is supporting decentralization of care and moving care out into communities and into clinics and hubs that are closer to where people are to address care access issues, but we're also able to learn from retail models about what works well with consumers on the patient side. So not just in the pharmacy or the clinic at the back of a CVS or a Walgreens, but how does that transition to technologies and capabilities that support convenient drive-up, contactless care and solutions that support the way, to Nate's point, digital natives want to live and consume their services and care. So we're seeing that even the cross-industry partnerships are driving new models into healthcare, because we can learn from what manufacturing is doing, what the supply chain and distribution space is doing to support all of those things. We don't see industries siloed as much as we used to, and that's a good thing, because we can learn from those models as well. So that's what we're seeing, and certainly following and embracing as we think about solutions and partnerships. Hopefully that was an answer to your question, what you were asking.
Yes, Nate, could you follow up and just add to what Leah talked about? And yes, Leah, that was perfect. Thank you. In terms of investments, where are we seeing, venture capitalists looking at right now? How do these small startups even begin to start thinking about raising capital?
Sure. I think that nowadays it's pretty easy compared to 5 to 7 years ago for a health tech startup to obtain venture funding. The stock market has overperformed significantly. These VC funds have raised a lot of money to deploy, and so they're looking for promising young companies. I also don't believe that having sort of that making a profit or a return on your investment is irreconcilable with healthcare. You can do both. I look at it as there is now money to fund these founders and entrepreneurs' new ideas, whereas there really wasn't a bunch of it 10 years ago. So I look at it more as a democratization of the opportunity to change how healthcare is delivered in our country today. So yes, it is a threat to the incumbents, but it's only a threat if they don't actually pay attention or assume that these are just a fad or a flash in the pan that'll go away. I think the selection of your VC investors is very important these days because the founders are in a much better position to be picky and choosy. There's even backlash within the VC industry at other VC firms because the money has gotten so big that they really wield private equity size cash deployments rather than a traditional maybe like 1 to 3 early a stage type of funding round. We're seeing $100 million Series Bs and 30, 40, $50 million Series As. And so if a founder in healthcare takes on too much capital too soon or takes it on from the wrong investors, it absolutely can skew their decision making because they would receive an inordinate amount of pressure to get a 10x return over 3 years on that investment, rather than use that money to build something that will help people and that will grow and flourish and be sustainable. Right? Yes, it is technology coupled with healthcare, that these are people at the end of the day being serviced. They're not in-app purchases on Candy Crush or Dragonville, right? So there are consequences to these actions. And I think the vast majority of these venture-backed entrepreneurs do have a strong moral compass, and they're getting into healthcare knowing it's complicated. They're also, as a VC mentality, as opposed to private equity or like a small business, they know they could fail, right? So they were receiving funding from investors with the directive, I want you to shoot for the moon. It is okay if the company doesn't succeed. We're willing to take that existential risk if you can do it right and do it big, because we are in the business of having transformative change for the way healthcare is delivered. I think that is riveting, that is exciting, and that is something that people should really embrace. Again, it is incumbent on the founders, though, to maintain adherence to their initial vision and don't allow it to be polluted by the small but present subsect of investors who just want a quick return on their money.
I think that's critical right now, Nate, especially when we just saw the announcement from Google about them, sort of dialing back significantly on their approach to market. And a lot of the buzz in the media and the healthcare space was, is it too hard to win in this space? Is it possible to solve for some of these issues? It is complex. So to see startups and innovators still eager to jump in and roll up their sleeves and say, no, we can solve for these things, and the willingness to take risk is critical because these are complex issues. There's a lot of people jumping into this space, but there's still some big challenges to solve for. And we could spend a whole hour here talking about the challenges of just RPM and how remote patient monitoring can be integrated into all of this, and who's solving for how those things get provisioned, where that data goes, how that data gets surfaced, the conversations it supports with clinicians. I mean, it's exciting, but it's daunting. And so it's so important that we're seeing an investment space still eager to lean in and help solve some of those complexities, especially at a time when others might be getting out of that space or shifting their focus and direction.
And Anne, I think you're positioned in a unique place with the American Telemedicine Association. I think the people you hear from on a daily basis probably represent anything from these giant behemoth telemedicine companies all the way down to someone trying to think of a startup plan or program. What are you learning from these people? Where are you seeing them starting? What's working? What's not working?
Well, as someone who funded at least 2 of our startups on credit cards, I would say that I'm very excited that there's more money coming into the market. And I think that's really encouraging. And that, there's this growing appetite for doing the right thing in healthcare. And I agree, Nate, there's nothing wrong with being for-profit in your orientation and still delivering value. I think even for-profit companies want to deliver value and do the right thing over the long term. So I think a couple of things that I'm seeing with new players and these new ventures emerging. So Leah talked about the issue of interoperability. This is actually something that technology lends itself to solving pretty readily, not easily, but readily. It can be used. And so seeing some very cool companies that are emerging to get the patient connected with the right modality. That could be phone, it could be video, it could be text, and then to the right clinician. So it streamlines that and integrates all the point solutions that a health system or a provider might be using or a health plan might be using already. So it's solving a real problem. And I think that's the hallmark of what these companies that are successful and have a good solution is because they're solving a real problem. This isn't their problem that they made up. It's something that's profound. The other thing that I think is getting so much better is the user experience, because we have historically, as an industry, not paid a whole lot of attention to that. And the reason why some of the newer companies are doing so well is because they've embraced the fact that they have to do a better job of that. Even, for people who have disabilities, folks that just don't have the ability to access things as services as readily as others. And then the final thing I'd say is the admonition. We talk about literacy and the ability to use technology or understand it or understand what's delivered to us. Lisa Fitzpatrick at Grapevine Health talks about it's our obligation to make it literate for the consumer. It's not the consumer's job to become literate in our solutions. So those are some of the fun things I've learned in the last couple of years.
And we are bumping up against the end of our session time today, but I would like to pause and just take a couple of minutes and do a round robin of sorts. As our audience is leaving our session today, what are a couple of takeaways that you hope people leave with? And Anne, we'll start with you.
Well, I think the big takeaway is to get involved. There are communities out there like the ATA that will embrace your participation. We are really committed to ensuring that telehealth is health, that it becomes a permanent modality of care that's decided on by the clinician in conjunction with their patient. And we just don't want to see that go away. So get involved.
Leah, what say you?
Yeah, I think the takeaway for us all, and especially for us at Verizon, is that real-time care anywhere is the model of the future. That doesn't mean you won't still go on site for certain things, but this is the direction that not only the industry is moving, but it's necessary. It's necessary to advance care and to really begin to address and chip away at the cost, quality, and access challenges we still face as a health system. So for us, that's always advancing and looking at how do we make this care more real time. We didn't talk about 5G here, but that's a big focus for Verizon. How do we enable telehealth capabilities in a very real time way? How do we extend connectivity and technology to those who really need it most, whose access to these capabilities is critical to their health and well-being? And that, like Anne said, if we lean in and support and all develop against our core competencies, we can meet these challenges. We can solve for so many of these challenges and see healthcare as a delivery system really transform. We're excited about that and excited to work with Anne and others and Healthcare Connect South to continue to get that message out for sure.
Thank you, Leah. And Nate?
I'd say that we've learned a lot of lessons in this period of time when all the rules basically went away, right? With all the way in that allowed and forced people to be creative at a rate that was faster than they were otherwise accustomed to. And believe me, within the health tech space, it's a pretty fast rate for creativity. I think we should embrace that and continue to look back and say, okay, how can we push this further, right? Good enough is not good enough. Right? And we do have tools now that simply did not exist 10 years ago. And it's that old adage, a ship in a harbor is safe, but ships weren't built to stay in the harbor, right? We really need to kind of push out. I miss the camaraderie and the idea generation from a lot of the health and health tech conferences that were in person. And people should know that just because there hasn't been in-person conferences for the last 18 months, that stuff is still going on with discussions among these thought leaders. And I really look forward to maybe in December or in 2022 when we're really going to have some of those opportunities for the in-person idea generation. That's going to be really fulfilling.
And Leah, Nate, thank you so much for your insights today. I personally have learned a lot from you, and I'm sure our audience members have as well. As we close out our session, my prediction is virtual healthcare is not going away. Virtual healthcare is just going to become healthcare. I think we're going to drop the tele on front of telehealth, and I think it's just going to become healthcare, plain and simple. It's going to be a prominent part of our healthcare moving forward, and for that, it's very exciting to me, and I'm sure for the three of you is exciting as well. Indeed, this is a space to watch. It's exciting. I don't know that I've ever worked in an industry that has moved as fast as this virtual care has in the past 20 months. It's been a whirlwind of learning and mistakes and backing up and moving forward for certain. So thank you all very much for coming today and sharing your thoughts on that. To our audience, stay tuned. Every day is a new news day in telehealth and in the virtual world. Thank you for your time and your attention today.
Thank you, Sherry.
Thank you, Sherry.
Thanks,
for having us.
Nate. Yeah, Nate.
Thanks, Nate, man.